Welcome to today's Research America Alliance member meeting. It's actually a briefing, and I think it's going to be a particularly valuable one. But first, let me thank you for being Alliance members, for joining us today and for your partnership throughout. Recently, we've been making many advocacy asks of you as we try to wrangle a supplemental funding bill out of Congress, and just appreciate your engagement, your ideas, and your partnership. A little bit of housekeeping. We are using Zoom today, as you guys all know, but we're going to keep folks on mute until after the panel discussion, since it's so easy to capture ambient noise with Zoom. Towards the end of the discussion, use the electronic raise hand feature, and we'll unmute your line for a question. Or throughout, feel free to type questions in the Q&A box, and we'll get to those after the discussion. I think, as you probably know, our briefing will explore research around injury prevention, including research focused on gun violence. Our panelists today are Dr. Rebecca Cunningham. She is the professor of emergency medicine at the University of Michigan Medical School. Dr. Steve Hargarten, Professor of Emergency Medicine at the Medical College of Wisconsin. Dr. Terry Richmond, the Andrea B. Laporte Professor of Nursing at the School of Nursing at the University of Pennsylvania. And Dr. Fred Rivara, Seattle Children's Guild Association Endowed Chair in Pediatric Research at the University of Washington. So we have a nice broad scope of experts here with us today. And our panel is being moderated by our friend and colleague, Dr. Ross McKinney. He is the Chief Scientific Officer at AAMC. And I doubt I have to spell that out for anyone in this audience. We all love AAMC. Ross, let me turn it over to you.
Okay, well, thank you very much, Elena. It's going to be an interesting conversation because there's a lot of ground to cover on this important topic. So why don't we start with Fred telling us about some of the research topics that you think could reduce the burden of injuries.
Well, I think, first of all, it's important for us to look at what's the burden of injuries in the United States and realize that 240,000 people died from injuries in 2018, the last year that CDC provides data. So that's more than currently have died from COVID in the United States, and that's every year. And there are about 28 people that visit emergency departments for injuries, and 2.7 million years of life lost before the age of 65. So the magnitude of the problem is really very, very large. Secondly, when we talk about injuries and trying to reduce the burden of injuries, I think it's important to think about it in three phases. So first of all, what can we do to prevent injuries from happening in the first place? And particularly for those among the most vulnerable groups in our society. Those are particularly people who are poor, people who live in rural areas, people who are minorities. Secondly, what can we do to better treat those who come to our hospitals or are picked up by our ambulance services for injuries? What can we do to reduce the risk of death in those individuals? What can we do to reduce the risk of complications and loss of function? And then the third thing to think about is rehabilitation of people who are injured. What can we do to get those people back to optimal functioning after their injury? I think it's also important to, when we think about the injury field, is that it's really quite broad. So it covers what we traditionally have called accidents, which we no longer call accidents because we know that injuries do not happen randomly. They are somewhat predictable in who they happen and how they happen. It also includes injuries that happen due to violence, homicides and suicides, assaults and suicide attempts. So it's really quite a comprehensive aspect of injuries. And right now, I'll just look at the non-firearm aspect of injuries and talk about some of the important research needs. There's a lot. And for example, traumatic brain injury is a terribly important problem. And there have been studies done on trying to reverse the effects of a traumatic brain injury. What can be done in the emergency department, in the hospital, to try to reverse the effects and save life and preserve function. And frankly, all the studies, randomized trials that have been done on traumatic brain injury have been unsuccessful. There really haven't been any good interventions that really, truly reverse the effect of the event that happens to an individual resulting in a traumatic brain injury. So we definitely need more research on how can we better treat individuals with traumatic brain injury. And this really varies from the mild traumatic brain injury to the severe traumatic brain injury. I'm a pediatrician and particularly interested in the problem of concussions. And we're still understanding what happens when an individual has a concussion and trying to understand better how do we treat those individuals with concussions and how do we best rehabilitate those individuals with concussions. Motor vehicle crash deaths has been in many ways a success story in the United States. If you look at graphs of the number of people who died from motor vehicle crashes per mile driven over the last century, there have been a constant, steady decline in mortality. However, there's been uptick in that in the last 10 years. And most people think that the uptick is related to distracted driving from cell phones. Cell phones aren't going to go away, we know that, and people are going to continue to drive and use cell phones. But how do we deal with cell phones and drivers, and how do we reduce the risk of fatalities and motor vehicle crashes in this whole problem of distracted driving? Another area just this week is there was a news report on suicide deaths among veterans in the United States. And that has increased this year compared to last year. And I want to just really defend the VA here. The VA has tried heartily to try to decrease the number of deaths from suicide. Every patient who is seen in a VA clinic is screened every time for suicidality. The VA, the military, has spent a ton of money on trying to prevent suicides, and yet they have not been successful. And in terms of suicide prevention overall in the general population, probably the only thing we know really works are antidepressants. We'll talk a little bit later about the role of firearms in those, but there's still much that needs to be done for prevention of suicides. And then finally, this whole issue of injuries to vulnerable populations, Hispanics, Blacks, people living in rural areas. I think what we have come to realize is that there aren't anything as accident-prone individuals. There are injury-prone environments. And how do we change those environments to make them actually safer and reduce the risk of injuries to those people? So I'll stop here for now with that. But there's clearly a huge need, a large magnitude of the problem. And the only way we're going to address that need is through better research to understand how we can better prevent and treat these individuals.
Just one follow-up question that maybe it wasn't in what you were pulling out, but on that 240,000, what were the relative sort of proportions of deaths related to injury? What were the causes? Are there sort of broad sense of an order or frequency?
Well, in the United States now, motor vehicle crashes and deaths from firearms are pretty neck and neck. Each of them cause about 40,000 deaths each year in the United States. That hasn't always been the case. Traditionally, there have been more motor vehicle deaths than firearm deaths. But as there's better cars, better trauma systems, better roads, the number of motor vehicle deaths have decreased dramatically, while the number of firearm deaths haven't. So those are really the two leading ones.
Okay. Did anybody else want to make a comment on any of the concerns? Okay, Terry, in fiscal year 20, appropriations included $12.5 million in funding for firearm research from the CDC and $12.5 million for firearm research of violence from the NIH. In your view, why is it important for both the CDC and the NIH to fund firearm violence research, and why isn't philanthropy doing enough?
So great question. Thanks so much. So here's the short answer. The short answer is you can never have too many agencies or foundations funding firearm violence research. All three, NIH, CDC, philanthropy, are very important, and they're all critical for us to address a significant public health entity. So no one entity is sufficient. But here's the background for that. So there's two reasons why I believe everybody needs to be involved. First, for people who have not lived and breathed firearm violence research as many of us have, it's important to know that funding of rigorous apolitical firearm research has been woefully lacking for decades. In fact, almost my entire time as a researcher, and since I have gray hair here, that's a very, very sad statement. If we think until last year, CDC has not really funded studies specific to firearm violence since the 1990s, and virtually less than 1% of their budget, annual budget, goes to firearm violence. NIH wasn't a whole lot better. So in 4 decades, from 1973 to 2012, I'm going to parallel 2 things. In 4 decades, there were slightly over 2,000 cases of cholera, diphtheria, polio, and rabies combined. And at the same time, more than 4 million cases of firearm injuries. So how many grants were awarded by NIH? Well, for the cholera, diphtheria, polio, and rabies combined, 436 projects. For the firearm violence, 3 NIH awards that were specific to firearm violence. So that's about 1 award per 5 cases when we think about the cholera, diphtheria, et cetera, and less than 1 award per million cases for firearm violence. So you could say, did philanthropy fill the gap? Well, over those decades, 2 or 3 foundations were in it and interested in funding it, but 2 or 3 foundations are insufficient to support the field. Then after Sandy Hook, which I think for many of us was just a turning point in this country, the community of researchers made a very strong recommendation to the Biden Commission that the federal government needs to invest in unbiased research and infrastructure. At that time, then, as a result, NIH put out program announcements. That was 2013. And those program announcements were like phenomenal. It was a great start. They ended up funding 24 projects, and 12 of those were specific to firearm violence. We've seen since then some separate specific calls from NIMHD, for example, on disparities in violence and firearm violence, or NIMH on suicide prevention, but not a whole lot of activity until, as your question asked, when Congress allocated $12.5 million to CDC and $12.5 million to NIH. Those projects were just awarded. Because yesterday was the end of the fiscal year for the government. CDC funded 18 projects, NIH funded 7 projects specific to this call. And of note, if you looked at NIH Reporter, there are 8 other active projects that are specific to firearm violence. So let me recap the short answer. You can never have too many agencies. The second reason then why I think you can never have too many agencies, the mission and focus across philanthropy, CDC, NIH differ. And therefore they fund different kinds of research. So let's think about that for a minute. We have a lot of interest now, not a lot, we have more interest now from philanthropy. So we have the National Consortium for Gun Violence Research. And that is funded primarily by the Arnold Foundation, but by some other foundations. And that mission is, the mission of that group is to disseminate nonpartisan scientific research that offers public and policymakers a factual basis for developing fair and effective gun policies. So it's very specific. The Joyce Foundation funds gun violence research, and they support research, education, and policy solutions to limit availability of firearms to those at risk. What about CDC? The overall CDC mission is to protect America from health, safety, and security threats, both foreign and the US. We hear about CDC every day now with COVID. Within CDC is the National Injury Control and Prevention Center. And they work to understand how injury and violence impact all of us. So they want to define a problem and identify risk and protection, develop strategies, and then create tools for widespread adoption. NIH has a different mission. NIH is the key national biomedical research driver in this country. And they seek they want to create fundamental knowledge about the nature and behavior of living systems and the application to enhance health, lengthen life, and reduce illness and disability. So all three groups have different foci. There's overlap, but there's distinct differences. So I would say, because there is overlap, that's a good thing, but the distinct differences mean all are necessary. So let's just think for a minute, because, and I'm going to give us an example that's not injury or firearm violence related, because, you know, firearm violence is a bit of political at times, and I just want to couch this in the broader world. Let's think about cancer. So we have the American Cancer Society, right, who raises money, who funds research. Their mission is to save lives, celebrate lives, and lead the fight for a world without cancer. CDC has two entities at least focused on cancer. One is their CDC Cancer Home, works on innovative communication to promote prevention, screening, early detection, and evidence-based programs. And they also have a huge office of smoking and health, so tobacco cessation, which is important for many kinds of cancer. And then we have National Cancer Institute, which is a huge institute within NIH, which looks at biology and biorepositories and nanotechnology and proteomics, and as well as prevention. So that they cross the board. So we see that those three entities in cancer have overlap and they have clear distinctions. No one would say, I think, oh, if cancer fits in NIH, why should CDC be involved? Or if the American Cancer Society raises money for its mission, why do we need NIH and CDC? So firearm violence should be no different. It is absolutely the same. So recapping the second reason why, we can say in firearm violence, each alone is important, but none alone is sufficient. So we need to do that. And then finally, I would propose that if you were a reporter, sometimes with reporters, I'll say, here's really the question you want to ask. So here I would say, maybe we could think of a more expansive question. Who else should be funding firearm violence research if we want to improve health and well-being? It's impossible in today's world, and for those of us who worked in this, to think of firearm violence in isolation of the gross inequities in society and of structural racism. We just can't. So if we think that's true, then we should say maybe other federal agencies should fund firearm violence as well, to look at upstream determinants. Department of Housing and Urban Development, Department of Labor, Department of Education. So all of those could be relevant if we think about upstream determinants of firearm violence. So that's my big picture. Everybody is essential. No one alone is sufficient. And I'm wondering, I don't want to call on Rebecca, I realize that's your job, but Rebecca's team published a terrific paper specific to adolescents and children about funding of research, and she may have some thoughts on this as well.
Yeah, thanks, Terry. So, you know, echoing a lot of those great comments and spinning off on them a little bit, and from Fred's comments as well, our group has spent a lot of time thinking, our FACTS consortium, which is NIH funded, has spent a lot of time thinking about children and firearm death. And the reason that we have done that is because we realize that firearms are the second leading cause of death and have been among children in our country for decades. But to Fred's points earlier on the larger burden of injury, we know firearm deaths have also been the leading cause of death among young Black men. Also for decades. So the burden of mortality and morbidity in our country for this has just been tremendous. In our state of Michigan, we have had more people die of firearm violence than of opioids in the past 5 years. That is true across many states in the country. It's surpassed motor vehicle crash deaths in the state of Michigan and across many states in the country as well several years ago. The reason you haven't heard more of those sorts of statistics is there haven't been enough people focused on the problem to produce the data. And one of the reasons for that is spinning back to what Terry talked about is there wasn't funding enough across enough agencies. And separate than the problem was if you don't have funding, then you're not having scientific inquiry move on. The other thing is if you don't have funding, then it is very difficult to motivate the best and the brightest in our fields to be studying these problems. I am coming to you today from the University of Michigan. Like many universities across the country, our faculty need to seek academic promotion, and that happens by publishing papers. It also happens by seeking external funding, foundation funding, but also federal funding. It was very difficult 10 or 15 years ago. I'm as gray as Terry is, maybe slightly more dyed, to talk a young researcher 10 years ago that was brilliant, into not studying the epidemiology of cancer, because I could point them clearly to an agency and billions of dollars of funding where they could go after that and explore a career. They knew that funding would be difficult in this area, and so they were discouraged. But yet we know that the funding for firearm violence being so much less than, especially among children, than it has been among cancer, but that more children die by gun violence every year than die by cancer every year. And so these are some of the inequities that we've been thinking about and trying to manage together. So when we think about who needs to fund this, as Terry says, everybody needs to fund it, and they need to fund it with a larger zero, or we're not going to move ahead. But the approaches are different and multifaceted. So the CDC, it's coming back to your original question, often focuses on the application of public health information into real world practice and translation. Very important. The NIH classically focuses more on the root causes and the measurement and methodology and the intrinsic front end questions. Those have not been answered at all in gun violence. It is not a translation issue what the best measurement tools are right now for gun ownership, or how we ask these questions among people. Those are root and methodological questions, and will need to be answered really with the same methodological tools that we would answer any number of other questions across NIAAA that has many millions of dollars of grants on how we study the methodology of alcohol misuse and abuse and the terminology of that, or among the drug, among NIDA. So these are the sorts of questions. There's many foundational questions that we don't even have to begin to have answered on this entire field, which has been understudied. And then also we need funding for application and translational research, which comes later on. And foundations typically also have gotten involved further on in the road. Classic foundation research, if we look historically, is more engaged when there are early solutions to problems and looking at getting those disseminated widely or out to particular groups of people, and are much less involved in foundational research. If we look to how we've solved other major public health crises in the country, from major epidemics, when we think about HIV, none of those have ever begun to be addressed without the NIH engaged and pulling on our full biomedical enterprise across agencies to address it. And we see that now with COVID. When we look at COVID funding, I was reviewing the other day where COVID funding has come across the agencies. It's come everywhere because it touches almost every part of many agencies in some way or another. And firearm violence is such a large problem for injury and mortality for the country, and touches so many places, from drug and alcohol to Department of Justice to root causes around structural racism. It touches so many of these areas that really we need to be looking at all of those different areas and permutations in terms of funding. So I'll stop there. Fred, I see you coming up.
Well, I just, you bring up COVID, and it's really an important point, is that the amount of research that's been done on COVID in the last 9 months has been unbelievable. It's the data show that there's basically 250 to 300 papers published a day on COVID, a day. And as a result of that, we've learned a tremendous amount about COVID. So that research has really produced tangible benefits for people in this country. It is making a difference right now in saving lives. We have that nearly that kind of research for firearms, when firearms cause a large number of deaths in the United States year after year after year.
Yeah, I think it's an important contrast also, because everyone understands COVID is caused by a virus, but because gun violence has seemed to many people in the country to be not a scientific problem, and a problem that is also of public health, but a problem that is somehow otherwise impermeable, related to social issues that can't be addressed or too big, that they don't think about it the way that many of us on this panel have been spent many years thinking about it, which is, as you started this conversation, Fred, the firearm violence prevention is injury science, and it is a science, and it has a theoretical background to it. That is well grounded in many socio-ecological models, a Hayden matrix, the same types of science that address concrete things that people understand, such as car crash. The way that those were approached were also from a scientific lens, and by doing that, we reduced car crash death. It was not politicized in the same way, although for those of you who are around in the time, remember actually addressing car injury was very political at the time, with the establishment of NHTSA and seat belts, and the public health messaging that went out around seatbelts in the time. It feels very familiar to what we understand about gun injury, as well as really masks or other things around public health that get politicized over time with personal freedoms mixed in. But underneath that, there is a science. There's a science to masks and COVID. There's a science to seatbelts and car crash. And there's a science also around firearm injury prevention, from everything from safe storage to areas and contexts and demographics that we know are at higher and lower risks, and why. And so one of the reasons I think the scientific community has been, one of the many reasons, been slow to take this up as a cause for funding is it has not always been seen as a science with a theoretical framework to be addressed, but instead something that could simply be legislated with a law.
Well, and I think, kicking off on what Fred said as well, so I agree with everything that you say, both of you say, but the other thing from a broad COVID, so Fred, you started with COVID, like look at everything that's focused on COVID. Well, COVID is in our face every day. We pretty much believe COVID is all of our problems, although our behaviors may not indicate that, but theoretically we believe that. I think there's large portions of groups of people who don't view firearm violence as their problem. It's not my problem. It doesn't happen in my community. It's not going to affect us. And therefore, politicians also don't see it as their problem. So, you could say, well, firearm violence is an urban problem. It is a problem. We see it on the news. It's people who don't look like us. It's an urban problem, without recognizing that when I live in rural America, firearm suicide is a huge problem, and it's disproportionately burdened on rural communities. So I think it's not just people don't recognize it as a scientific field, and because it's not funded, is people somehow can distance themselves and say, this is not my problem. And therefore, politicians can say, this is not my problem. And therefore, distribution of funding for things can be driven by, this is not my problem, when in reality it is.
So if you were going to put together a package, Fred, of what kinds of topics would be high on your list to be funding, what sorts of things would be in that list? And we can run through everybody, so keep track. Right. But what would you be funding in firearm research?
Well, I think Terry just touched on a very, very important issue, which is that of the 40,000 people who die each year from firearm injuries in the United States, 60% of those are suicide deaths. I mean, you come from, Ross, at AAMC, from a healthcare background. All of us are in medical professions here. And I think all of us can really own that suicide is a problem for the medical profession to deal with. We can talk later about whether homicides are or not, but certainly suicides are. And in fact, in 44 states, there are more people that die from suicides with firearms than die from homicides with firearms. So in the vast majority of the country, this is really a problem that we as health professionals really need to own up to. And to answer your question is, well, what should we be doing? Well, I think that we start with the premise that we live in a country that has the Second Amendment, and that's not going to go away. And we have probably 300 million guns in circulation in the United States, although we don't know the exact number because the federal government prevents those data from being collected. But starting from that, we have to think about, well, how can we reduce the burden of firearm injuries and deaths in the United States? And you mentioned Sandy Hook before. And after Sandy Hook, Steve was a member of a National Academy of Sciences committee that produced a report on priorities for firearm research. Unfortunately, those priorities and questions still exist because of what Terry said about the lack of funding for firearm research, except for the last couple of years. And there are lots and lots of questions which really are relevant. What's the motivation behind gun acquisition and ownership? How is this distributed? When do young males, for example, start carrying guns? And what is the reason for carrying guns? Do they perceive it as protective of them or not? It is in fact protective of them or not. What is the degree to which any kind of education programs, whether it be for younger children or for the public, what are the role and what's the effectiveness of those in terms of reducing firearm violence? What's the impact on public health of removing firearm ownership from some people who are disqualified from owning guns by the federal regulations in the 1964 Gun Control Act? Are they effective or not? Are we really identifying the people who are at highest risk, or are there other groups that in fact are much higher risk of owning guns than those which meet those federal disqualifications? What's the effect of firearm violence in the community? I think that with the Newtown shootings and Sandy Hook shootings, they really shook the country to its core in many ways. The idea that 20 some odd children would be murdered by somebody with a firearm. That had an effect upon the psyche of all of us. But these injuries happen every day of the week. What's the effect upon other people in the family? What's the effect upon people in the community? What's the effect upon kids that attend those schools or other schools where there's been a school shooting? Are they now afraid to go to school? Are they, what's the kind of PTSD that they have after this? And what is the best way to treat that? We really still don't really know very well how to treat PTSD or prevent PTSD. And I really worry tremendously about the exposure of all of these kids to firearm violence and what's the effect upon them. I mentioned earlier the whole issue of firearm suicide. And what can we really do to prevent those firearm suicides? We know that for the most part, there's not a substitution effect. If you take away guns, suicide rates go down. But how can we appropriately restrict access to firearms from people who might actually use those to harm themselves or others? And then, there's been a lot of, we've mentioned today a number of times how there's been improved motor vehicles that's resulted in reduced motor vehicle fatalities. What can we do to change the design of firearms to reduce the lethal threat, and particularly those things that are we might be able to prevent access of individuals who shouldn't have access to be able to not actually fire the firearm? What's the kind of technology that might be available? There really isn't any widespread technology out there that can be put into guns into manufacturing. There's zero technology that can retrofit guns to make them safer. Those are big questions. In a country that's so technologically advanced as the United States, it's remarkable to me that we haven't been able to figure out technology to accomplish that, to make guns safer. So I'll stop there and would like to hear what some other people say about what are the next steps in research for firearm violence.
Let me just add to those comments, Fred, and build on the great comments made by my colleagues. First of all, in terms of history, with NHTSA, they had an allocation of approximately $200 million per year for research in identifying and preventing the causes of motor vehicle crash deaths and injuries. So that investment was up front back in the 1960s, and we benefited from that. Here at our own institution, we recognize that the approach to taking care of a patient with a gunshot wound requires a team approach of a surgeon, a health psychologist, social worker, combining together to identify the risk of post-traumatic stress, as Fred has identified. What are the best intervention models that help to maximize the outcomes of these individuals who go back into a high-risk environment? And what are some of the other questions that we need to have answered to maximize the treatment of these patients? The research agenda is broad, and I think the NIH has an opportunity to pull in disciplines that otherwise have not been traditionally pulled in together to start answering those questions that are, again, contributing to the vexing challenge of addressing gun violence in our communities.
I'm going to jump in on Steve, and I reinforce, I think, what's been said, but say it slightly differently. And here's why I think having a robust funding program in NIH is so important, is prevention is phenomenal. That's the best thing that we could do. But whether we prevent or not, people get shot, people are going to hurt themselves, people need acute care, and people need to fully recover. So as a nurse, I really care about the recovery piece. That's really where my research lies. And when we sort of, how we think about it at the Penn Injury Science Center is our outwardly facing motto is we stop it, we fix it, and we live on. So I think it's important to really remember that trajectory and say, all of those are important. There's many, many ripe questions within the stop it, fix it, and live on that really would benefit from rigorous scientific study. And the living on is not just the individual who was shot. It's the kids who witness it. It's the people who live in pervasively violent neighborhoods. It's the fallout on the communities. It is broad from individual, family, community, and society. There's fallout in society, there's no doubt. Think about the media exposure we've all had to violence now and violence in the streets and the effects on that. So we really need to say these questions need to cover the entire trajectory that's related to firearm violence and violence in general.
I would love to add to that a little bit. So to the original question, so the FACTS Consortium, of which folks here are part of, last year put together the 26 top priorities for what we thought were the next questions to address this. And although I think those questions are important as we think about it, I think the more important concept is the one that Terry just raised, which is there's not one or two things here that are the next right thing to be looking at within gun violence. And instead, and I will quote David Hemingway and give him attribution here, if you think about, in some ways, the lay public is still asking the naive question of, what's the one thing we should do to address gun violence? We wouldn't ask that. We wouldn't say, what is the one thing we should do to address cancer? Because cancer, we understand, is a very heterogeneous disease that is a lot of different things to a lot of different people, and gun violence is as well. And so because we're just at the very beginning, the CDC funded the first grants in 20 years last week, we have many aspects to look at. So just as though there are hundreds of types of cancer, we have gun violence among children in rural areas, we have urban gun violence, we have elderly gun violence and suicide, which is skyrocketing. One of the largest populations that are expanding for gun death in the country are older white men and suicide. All of these niches have different areas and focus and different specific questions around them, and will have different approaches. They have a common entity of a gun that is involved with them, but how we address it before and after that are going to take a very heterogeneous approach. And one other thing I think that's important to raise that came up before is when we talk about the invisibility of how people feel this affects their communities, is that this plays into also the stigma around suicide. So many physicians and medical schools in more rural areas feel that they don't have any gun violence in their community and therefore are not as personally motivated about it. And I too, as an emergency physician, my colleagues in emergency rooms in those areas of the country don't see gun violence, and that is because 95% of suicides by gun die in the field and go directly to the morgue. And so those communities are tremendously impacted. And in the New England Journal article that we did last year, what we found is that children, the rates of death by gun are the same in rural America, urban America, and suburban America. The type of death is different, whether it is suicide or homicide, but our children are dying by gun violence in the same rate in those areas. But one is much more invisible. And that's part of, we need to make it more visible, and then we need to try to apply the tactics through this heterogeneous approach to addressing all of them.
So one of the things that's been raised, because you've all talked about, the gap in funding, the fact that it's been a long time, 20 years since there's been funding. Careers. Do you think that there are careers for people to look at gun violence or injury prevention at this point in time? And so what do you encourage and what are you doing to try and develop the next generation of scientists looking at these kinds of questions?
Well, I'll start there and then hand it off. So I have to say, I can't be more excited about this part, that even in the last 5 years, and I'll credit the NICHD and the NIH's funding of the FACTS Consortium, certainly for a big portion of this for us, which is in the building of that consortium, we now see, even in the 3 years since we've been holding conferences, an outpouring of young trainees, of people applying for postdocs, for training opportunities, who are interested, and partly because they see people like this across the field now able to research it publicly. They also see a field that is possible to apply for funding on. They see journals that will take our articles, of which was a question 10 years ago, whether journals would be accepting of articles with the F word and a capital letter in the front. All of these things we laugh, but are very true. And so now that those stigmas have been removed, we see an awful lot of junior trainees wanting to come along and beginning to come along in the field. We need more of our senior colleagues to take their relevant disciplines that they have and pivot towards adding on firearm violence to it. Folks in alcohol violence and drug research and criminal justice work and sociology and gender research that have all been working in related fields at a very high senior level. And they need to also add in the corollary and questions that are related to firearm violence, and then bring a junior colleague along into that to be moving it along. We need to expand the field, and the field is there now.
Anybody else want to comment on that? It's something that affects just about everybody.
Well, I'll comment. I thought Fred would, because Fred's had his T32 for so long, but I'll start, and then Fred, you can kick in. How's that? I agree. I think we absolutely have to commit to bringing the next generation of researchers on board. I think we need to look at, do we have sufficient training grants and funding opportunities for that? So as a nurse, for example, the focal areas within, for example, the National Institute of Nursing Research don't really embrace or incorporate violence in general or firearm violence. So we need to help people broaden their thinking. The second thing I would suggest is, but we prevail. The second thing I'm going to say is, we deal with a lot, we know that firearm violence disproportionately affects minority communities, underserved communities, vulnerable communities. But our workforce within the field of researchers studying firearm violence is predominantly white, not exclusively, but predominantly. So we also have to commit to diversifying our workforce and thinking about that very carefully as we bring on the next generation of scholars. And there are strategies to do that, but we have to commit to doing that, because I think it will enrich how we think, the questions we ask, and where the science goes.
At the University of Washington, we're certainly seeing an increase in interest in this problem. Like one of the postdocs that's funded by the FACTS program is working at the University of Washington, and she did her PhD on injuries. We have I have a T32 program, which I've had for more than a decade. And one of the people starting actually today is an individual who just finished up a PhD on firearm violence. So in the past, where I was not really encouraging people to go into it because I felt like it would be very difficult to get funding for their career, get a career development award or an R1 grant. I'm much, much more positive about that now. And I think that I agree with what everybody else has said. We really need to actively encourage those individuals to look into this field. And I think that they're interested in it. I think that there's been a long interest in violence, but now with the possibility of actually having a funded career in that, I think is going to attract many more people to the field.
Steve, did you have a comment?
Well, I just want to add that there's other sciences that can be also pulled into this field, and we're seeing more of that. Again, health psychologists looking at this as a career area to improving the treatment of gunshot wound victims. So there's other sciences that can and should be pulled in, and it should be visible to these young researchers who see, boy, this is a career pathway. They see that in cancer, they see that in heart disease research. It's not that visible at the NIH that this is a career path. And I think that's an important element to stimulate these young investigators that this is a career worth investing in for the next several years.
Okay.
One other thought, if I can, Ross, is that okay?
Yeah.
And so I'm going to go back to the FACTS Consortium. So this is related to the diversity thing. We can be entrepreneurial in how we fund our doctoral students and our postdocs. We can think about how do we, at PISC, we talk about a patchwork quilt of funding. We don't have a T32, for example, related to training pre-docs and postdocs, but we pool across schools amongst injury researchers our funds to fund postdocs, for example, which is hard to do, as you know how siloed some universities are, but we've done that very, very well. And then Rebecca's FACTS Consortium, I have a diversity postdoc where I have Penn invests in diversity postdocs, and Rebecca supporting the other half of that in terms of building the next generation of a diverse workforce. So I think if we, I always thought it was great to work across the schools and the disciplines of Penn to pool our money and trust each other enough that we were doing this for the better good. And then I think the FACTS Consortium is that on steroids. And I think that is phenomenal, and we have to be entrepreneurial to really move this generation along. And that would be consistent, I think, with the National Academy of Medicine report on the next generation of researchers, like really moving that needle.
Okay, we have time for one last question from us, and then we'll switch to the questions from our listeners. And that's the question of, and I'll send this to Steve, how much do we need to start opening the research to things like more biopsychosocial modeling? We need frameworks, and I think we heard a question about frameworks earlier. Is that an area that there should be more research?
Well, I'm excited to see a lot of movement in what is now commonly being referred to as beyond Flexner. You think about the history of the extraordinary gains we've made over decades of biomedical research investment. It has paid huge dividends, and we're benefiting from that. But I think we're at a point where, in broadening our investigation of complex diseases like opioid overdoses, and COVID is an example that's been brought up, the psychosocial elements of these vexing problems deserve to have a unified platform of investigation. And that's where I see a biopsychosocial model increasingly being discussed, talked about, and research finding out some answers by virtue of combining this under a platform and then unpacking it as appropriate. So I think we're in a point where this could be a modeling for NIH to consider, again, not confining it to gun violence, but using gun violence as an example of the importance of pulling in the biopsychosocial elements that inform acute care, rehabilitation, and further informs prevention. And I think that this is a very timely point that is being increasingly discussed. Social determinants of health is being increasingly discussed in our medical schools and our academic healthcare campuses. And so I think that's a real important area. And I think, Terry, you've had some good quality outcome studies that have really framed it in this way that's helped to inform the questions that you asked, and perhaps you could elaborate on that with the work that you've done.
So I totally agree with Steve, and so I won't repeat what you said, but I'm going to say, I think there's so much hope for a more integrated and broader than just the classic biomedical model in research. And I think even within NIH, I mean, NIH says it's a biomedical enterprise. It is a biomedical enterprise. But, you know, NIH is not a monolith. Like, it's made up of multiple different institutes. And as you look at some of the institutes, and I'll pick on NIMHD right now, which is maybe a 10-year-old institute at NIH, they very much do incorporate the biopsychosocial model. They very much do go from individual to society, take into account environments, take into account upstream determinants. So I see movement even within NIH that makes me hopeful, because if I personally believe if we purely attack firearm violence within a tight biomedical framework, we're never going to optimize outcomes for people and for communities. So I totally agree with you, Steve. It's absolutely essential.
Yeah, this seems like one of those times where, you know, social determinants of health, how could you come up with a more classic interaction? Because there's so many social determinants, including suicide. I mean, this is a social problem as much as it is a biomedical, in the classic biomedical sense. So need that kind of broad overview. Well, this has been a really good discussion, and it's the point at which my screen goes blank, and I'm supposed to say, let's hand it to Terry and see what questions we've gotten from the audience. So on my blank screen, I say, Terry, it's up to you.
Thank you so much, and thanks for such a great discussion. We do have some questions, and again, I encourage those watching to go ahead and type those into the Q&A box. One question already, given its role in improving the healthcare patients receive, we do know that the Agency for Healthcare Research and Quality is underfunded, but does anyone on the panel see a role for ARC in injury prevention?
Don't all speak at once.
Yes, if we think about healthcare systems and systems of care, and we think about structural things that contribute to inequities in care that people receive, I think there's a place for ARC. They are underfunded. I'm not going to name names, but Fred, I know somebody at UW had a great score and couldn't get funded in the injury world. So, you know, the funding level is problematic, but if we look across the continuum from prevention to improving outcomes, there is a role for thinking about the portfolio of ARC. But I'm not funded by ARC. I don't know if others are.
I think I would add to that in terms of thinking about a system of care and in terms of thinking about what we know about
Uh-oh.
You froze, Rebecca.
You froze. We're all getting used to this. This is the Zoom moment. Rebecca, you just froze. You've unfrozen. I see your face moving. This is a good sign. So you could repeat the last few paragraphs, because you were locked in ice.
Hopefully in a pleasant way. So in the way that we think about violence as a recurring and chronic disease in some ways, and that we see recidivism often, or one type of even childhood violence going on to manifest in some other either chronic disease and or in later violence, suicide towards self or others, thinking about ARC as a funder of systems of care would be an important part of firearm violence.
And want to build on that. I think that if we're going to pull in social determinants, we need systems of care, because as an emergency physician, I was steeped in the biomedical needs of the patient in front of me. But the other issues that can be and should be part of a system of care for patients and their families, we need that in order to pull in these other elements that are outside that immediate biomedical treatment of a patient. And so I think ARC is a great example of another agency to build on Terry's comments. Let's all be working together across these federal agencies towards a common goal of systems of care that comprehensively take care of patients and further inform prevention strategies.
Yeah, you know, you think of the last letter of ARC stands for quality, and I think we need to really understand that providing quality of care to patients who we treat with gunshot wounds means that there's a lot of other things we need to be concerned about. We need to think about the psychosocial effects of being shot on them and their families, and we need to do something to prevent recidivism, because we know that without an intervention, you know, 25, 30% of those individuals in the next 5 years will be back with another gunshot wound.
Terry?
Great. A couple of other questions that have come in. Terry, you mentioned the interest in NIMHD, the Mental Health Institute. How does preventing injury in high-risk groups, I'm sorry, that's Minority Health. There are too many acronyms. The Minority Health Institute at NIH. How does preventing injury in high-risk groups aid in achieving health equity?
Can you just repeat that one more time?
Yes, I'm sorry. I had trouble speaking. You mentioned an interest in the National Institute for Minority and Health Disparities. How does preventing injury in high-risk groups aid in achieving health equity?
Well, we know that certain high-risk groups are just bear the disproportionate burden of injury. So we know that there's disparities, right? So the question is, where do those disparities come from, and how do we tackle those disparities? So I think equity, does everybody have equal opportunity to stay safe? Does everybody have equal opportunity to be as healthy and safe as they can be? Then looking at studies that identify points of intervention to allow that to happen, to improve safety and decrease injuries from something like firearm violence, absolutely is within the portfolio and a focus of NIMHD and an appropriate focus. And one of the reasons I think they have that broader framework, if you're not familiar with it, go to their website, it's very good, is to really say we're looking at individuals situated in communities, and factors within the community may place you at risk in ways that if you lived in my community, you would not be placed at risk. So, you know, it fits right in there. I hope that answered the question, or if other people have thought. Go ahead, Fred.
Well, just, you know, I think that many of us feel like firearm injuries have the greatest disparity of any health problem in the United States. I mean, if you just take, for example, looking at, I pull these data out before, males 15 to 29 years of age, that Blacks have a firearm homicide rate that's 29-fold greater than that for Asian American males. 29-fold difference. There are few health problems that have such big disparities. So I think by addressing the problem of firearm violence, inherently we are going to be addressing disparities.
And I'll just add to that as another example. So if you look at suicide and firearm suicide, Native American adolescents and young adults are at high risk. We think of older white men as high risk, but Native Americans in terms of firearm suicide are high risk. So, I mean, it's really rampant within this field, and just so in need of research.
Great, thank you so much. A couple of other questions. It was mentioned earlier that the CDC just came out with some new grants. Have there been other injury prevention research, recent milestones or key findings that have been realized or announced recently?
Well, I think with the current funding cycle, since it just started in 2020, and the grants were just announced last week, and NIH, some just came out like on the 30th, which was yesterday. We don't know the results of those studies. We're positive in terms of building the science in those areas. And so just the fact that they're funded, they're out there, you can look at what that portfolio looks like is absolutely light years ahead.
I think one milestone, it wasn't this year, but it was a year or two ago, that all 50 states now have violent death reporting systems in place, building on what has been done for decades with motor vehicle crash deaths. So we've reached that milestone of having every state having some level of quality information that's linked to better define firearm related deaths and non-firearm related deaths related to homicides and suicides. So that's I think a milestone that we've achieved, and that work began in the 1990s. And so I think that's one element that we're very pleased to see happen.
I would add, I think there's a milestone that we don't yet know about, and that's partly due to the lack of our great data on this at all right now. So in the last 6 months, many people would like to know in our time of COVID, what's happened with firearm violence. There's a lot of conjecture about it. And there's pockets of it, some of it coming out of Therese's shop and Terry's shop at Penn and other places around the country. All the glimmers that we have of data show us that gun violence death among pretty much every group is higher now than it was before, and that includes the mental health and the suicide issues, as well as domestic violence and children who are now home more and finding guns that are unlocked. But it's not a milestone number to announce because our system of reporting non-fatal firearm deaths is so bad that we won't know. For the official counts will be out in 18 months from now. To tell us what actually happened during this time, and that is a milestone that we should know now. In the same way that we're able to count COVID cases every day, we should be able to know in our country and have a reporting system for that. The National Violent Death Reporting System is not sufficient. It is going the right way, but it is not sufficient. We need to understand non-fatal injuries, and that is a milestone that we need to work together towards being able to give in real time.
Great. That's a question that I think is on everyone's mind. So a final question, and this one a more hypothetical. Suppose this evening you were socially distantly able to speak to your candidate for Senate or for the House of Representatives. What might you urge him or her to do on this issue? From a distance, of course.
So there's more federal firearm funding. On the slate, there was 25 million passed this past year. The number that was dropped from 50 million. By passing that sort of funding and getting the money into scientists' hands, we likely will find solutions. I often will talk to people that in 1965, when brilliant politicians decided to fund NHTSA, nobody could have predicted that airbags would be the thing 20 years later that would save a lot of lives. Airbags were not dreamed up in Washington, in DC, sitting on a bench somewhere. Airbags were dreamed up when politicians funded scientists to think hard about it and do rigorous research and move towards scientific answers in engineering, as Fred mentioned, answers in social science and social justice. So we need to get that funding out. The 25 million we had last year is a great start. We need to add a zero, but I'll take another 25K, another 25 million. Thank you.
Anyone else want to comment on what they might say?
Well, my understanding is right now there's 50 million on the table where it started last year, and it hasn't been cut to 25 million yet. So I would say double it. It's a good thing, and if you want my vote next time, that's what I want to see.
Same with me, and get up to 200 million a year, just like NHTSA. We need to invest more.
When Joe Biden was vice president, he headed up a commission for President Obama on firearms and firearm violence. And hopefully when he's inaugurated on January 20th, he'll take that same program and put it before Congress, and hopefully Congress will vote to fund it.
Great, thank you. And I will use this opportunity to remind our listeners that we've just launched a nonpartisan candidate engagement initiative called Vote Science Strong to give everyone ideas on ways to engage with their elected officials who are running for office. I can put information about that in the chat. One final question. Recently at Research America's National Forum, Dr. David Williams of the Harvard School of Public Health called for a Marshall Plan to address the systemic issues of community at risk, including the higher likelihood to experience violence. Any thoughts on if such an approach might have potential?
I would welcome that approach. In our county, we have seen a significant increase in firearm-related deaths, and it would be terrific to have a coordinated Marshall Plan to affect those communities at risk, to really make a difference in those high-risk areas that pop up for COVID cases as well as homicide cases. So I think a Marshall Plan would be terrific to invest in communities across the country to work towards violence prevention.
I guess what I would say is I'd be cautious. That Rebecca mentioned this earlier, cancer is complicated. Well, firearm violence is also complicated. And the idea that we can easily solve it with a Marshall Plan, pouring money into communities without changing a lot of the structural racism and other factors which underlie firearm violence, I think it'd be unrealistic to think that the Marshall Plan for firearm violence would have a huge effect.
Okay.
But kicking off on that, it might be worth thinking about the cancer moonshot, right? So if we think about the cancer moonshot, what have we thought about the moonshot to get rid of firearm violence that affects everybody? That would be phenomenal. It would be integrated across agencies. We would have money poured into it, and scientists could do their work. So I could support that within a broader biopsychosocial model, but that would be absolutely phenomenal, I think.
Yes, and I agree, Fred, with your comments. I think we have to be cautious and not be just throwing resources out there without very focused strategies to address these vexing issues and underlying issues. Just a proud note from Milwaukee. It was at one time in 1929 recognized as the healthiest city in the United States. Why not, by 2030, have our cities being the healthiest and safest cities that we can be, and for that matter, even the rural areas as well. But I think it's important for us to be thinking about big pushes with resources to really make a difference.
Well, Ross, I'm back on, and I'd like to say that was a beautiful way to close this discussion with such a vision going forward. And I think a lot of the theme here is that, you know, this is complex, but that doesn't stop us. We've got to do something about it. And we've got to do something about the fundamentals behind it that feed into it, the social determinants of health, the social determinants, you know, period. And I just would like to thank you all. It was just really a pleasure to have you. You know, this kind of diversity of thought and thinking is exactly what we look for in briefings like this. We're a nonpartisan organization. I'd like to reinforce that. But we love the openness of views and perspectives. So more to come, and thanks to all of our members and everyone who could join us today. And thank you, Ross, in particular, for being such a stellar moderator, as you always are. We so value you. So thanks, and we'll just, we'll make that a cut. Is that the right word? I don't know. Make that whatever. We're going to close off now. Take care, everyone.
Thanks,
Thank
Ellie,
you.
for your
Thanks
time.
so much.
Thanks for
Ross.
this.
Bye-bye.